Welcome to the Module 8 tutorial, where I will be discussing treatment of musculoskeletal conditions. Before we get into the various treatments, I would like to review some diagnostic testing information that is not included in your textbook. Please use this first part of the tutorial as a supplement to the information in Chapter 52, which goes over how to obtain an accurate history and perform an accurate assessment of the musculoskeletal system. I'm also going to put the videotape that we did of the musculoskeletal assessment from the on-campus lab into the optional material in this module. This chapter also introduces you to some of the diagnostic testing, which I'm going to expand on next. First, I'm going to discuss some diagnostic testing for musculoskeletal conditions. Remember that pain and weakness are both very subjective symptoms. When you consider the need for diagnostic testing, it's important that you do a very thorough physical examination to determine if it's just the patient's perception or if there are assessment findings to support a significant musculoskeletal condition. You need to determine if it's a generalized condition or a localized condition. That will direct your diagnostic testing decisions. Remember that depression, anxiety, and stress can manifest as fatigue and weakness with a normal musculoskeletal system. Conversely, vague symptoms of fatigue and weakness may be symptom of a serious illness like leukemia or HIV. It is important to individualize treatment plans in order to specific tests you need to rule in or rule out specific diagnoses. Don't just order a bunch of tests and hope you find something. You need to be looking for something very specific when you order tests. It is reasonable to do watchful waiting with mild symptoms, but persistent or severe symptoms that interfere with activities of daily living should warrant a workup. So let's talk about some of these tests and how they may be useful. Don't forget to consider side effects of medications such as statins, which may present with symptoms of myalgia. Patients may complain that they can't get up a flight of steps or they can't get up out of a chair. It's usually a more abrupt muscle weakness. It's not like a muscle fatigue that occurs with long activities. It's usually an exhaustive muscle weakness. Beta blockers may produce bradycardia that causes hypoxia in the tissues, or where the expected increase in heart rate can't occur and it's not sufficient enough to meet metabolic demands. Heart failure should also be in your differential diagnosis list when patients present with muscle fatigue and activity intolerance. Complete blood counts are non-specific for musculoskeletal disorders. You may want to consider this test if the patient also has some degree of fever, you suspect an immunocompromised state, or they also present with diffuse aching bones, as their white count can indicate infection, immune system functioning, or serious disease. Anemia would most likely present as muscle fatigue and weakness due to the delivery of oxygen to the tissues. Patients may say they can't get through their normal workout without having to stop and rest. They can't complete their normal work duties or chores or other sustained activities. It's usually not a short-term activity complaint. So this is more with endurance type of activities. The comprehensive metabolic panel will provide information on the chemical balance and metabolic state of the body. Low electrolytes with increased renal function may indicate something as simple as dehydration. Elevations in renal function alone may indicate renal disease or renal failure. So it's important to look at the GFR if the BUN and creatinine are elevated. Elevations in ALT and AST may indicate liver disease. Hypothyroidism may present with muscle fatigue, and hyperthyroidism may present with proximal muscle weakness, loss of muscle tone, and evidence of osteoporosis. Vitamin D deficiency can present as gradually increasing muscle weakness over time. Patients may report that their activity level is significantly diminished now compared to a year or even 6 months ago. Again, that's usually not an abrupt change, it's more insidious. Your ESR, CRP, RF, and ANA tests are nonspecific indicators of inflammation. So again, that's your erythrocyte sedimentation rate, your C-reactive protein, rheumatoid factor, or anti-nuclear antibodies. Those tests, again, are all very nonspecific indicators of inflammation. They should only be ordered if you suspect a certain disorder where their results will either confirm or rule out your differentials. They should not be used as general screening tests. Remember that it is normal for the erythrocyte sedimentation rate to gradually increase with aging, but significant elevations can occur with infection, inflammation, and malignancy. But again, it has very low sensitivity and specificity. It's just a generic marker of inflammation. C-reactive protein levels are more often used in detecting bone or joint inflammation, such as arthritis or systemic lupus erythematosus, and is less useful in muscular conditions, so it's generally not one that's recommended if you suspect a muscular problem. Rheumatoid factor should only be ordered if you suspect rheumatoid arthritis or an autoimmune disorder, which also can elevate the rheumatoid factor. Antinuclear antibody testing may be more useful for musculoskeletal complaints if you suspect lupus, connective tissue disorders, Sjögren's syndrome, scleroderma, polymyositis, dermatomyositis, or rheumatoid arthritis. Lyme disease testing should only be completed if you strongly suspect the condition in an endemic area or if the patient has recently traveled to an endemic area. It's used to confirm your diagnosis, and remember that the test can be falsely negative in the early stages of disease. Patients with rashes resembling erythema migrans or with arthritis, a history of a rash resembling erythema migrans, or a tick bite should have treatment initiated regardless of the testing. Uric acid levels should only be ordered if you suspect gout. I attended a lecture this past March that I felt was very helpful in determining what imaging studies are appropriate and when. Dr. Lee Sherman presented what he felt was important for practitioners to know about radiologists when ordering and interpreting test results. So he is a radiologist, and these recommendations come from his lecture. He says that radiologists are intentionally vague. They are not the ordering physician in most cases and tend not to have the information they need to correlate with the test they are reading. They often recommend other testing without thought, basically to cover all bases. You do not need to follow their recommendations if they do not correlate with the patient's clinical picture, because again, they don't have all that specific information. Remember that the radiologists are usually available to discuss cases with you, and consultation is key if you're in doubt about the usefulness of an imaging study. Radiologists are biased in that they will call it as they see it, often without sufficient patient clinical information. Less testing is often more helpful due to overdiagnosing or false positive results. So, less is more, and if you're in doubt whether the test is going to be useful or not, it's best that you just pick up the phone and consult with a radiologist. That's the way you're going to learn. Due to the overuse of imaging, which contributes to the high cost of healthcare, many imaging studies now have to be prior authorized and will only be approved if select clinical indicators are met. Federal law has also initiated a clinical decision support program, which mandates that all Medicare recipients that need to undergo testing have to go through this authorization process starting in January of 2020. The American College of Radiology has an extensive website that provides criteria on what is appropriate to order and what is not appropriate based on evidence, and it can be accessed at the link that I provided on this slide. I will also put the link in the optional materials section of Module 8 if you'd like to go to the site and look at it. It may be something worthwhile to bookmark for when you are in practice. This is just one example that you'll find on this site. The soft tissue masses criteria is 10 pages long and provides evidence-based explanations for all the designations. The site also provides you with the information you need for the Medicare program. It is a site where you have to enter the patient information with objective clinical information, and then it directs you to the appropriate test. Non-compliance with this by year 2021 will affect Medicare reimbursement for the radiologists and the facilities performing the tests. If you're ordering inappropriate tests, you most likely will receive a phone call saying the test is unnecessary or that a different test is recommended. Again, this is something that the radiologists actually have to plug it in when they are putting the test order in. You don't want to order a bunch of tests just because you don't want to miss something. You need to make sure it's appropriate. So again, very focused testing. This is an example of part of the information on a cardiac CT for calcium scoring off their website also. Your book does a good job of walking you through the formulation of differential diagnosis for common complaints and review of advanced assessment techniques, so I'm not going to go through all that in detail. Instead, the rest of this tutorial will focus on the specific musculoskeletal disorders and how to treat them. But I do recommend you take some time and really read Chapter 52 very closely and look at some of these links and become familiar with them. So now I'm going to jump into Chapter 53, which is your spinal disorders. When a patient presents with cervical spine pain, a detailed history is essential. When you do your examination, if there are any neurological defects in either motor or sensory nerves, an MRI should be obtained. If there is history of hyperextension, like whiplash injury, there's localized tenderness when you palpate, it hurts on the cervical spine. If you see visible edema in the neck or bruising, you should order plain films to rule out a cervical fracture. You should also, if they walk in your office, immobilize them. Uncomplicated cervical spine pain without a history of trauma, no neurological deficits, and minimal physical examination findings should be treated conservatively with nonsteroidal anti-inflammatories, possibly muscle relaxants if there are spasms present. Patients with persistent pain should be referred to physical therapy. Avoid cervical collars unless you are stabilizing someone that you suspect may have a significant pathology, or if patients fail conservative treatment. Remember, when the patient wears a collar, they don't have to use their muscles to hold their heads up, and the muscles may atrophy and weaken, causing a longer recovery time. So you really want to avoid C-collars if possible. Spasmodic torticollis presents as neck pain with the head pulled to one side. That's what's pictured on this slide. And it differs from congenital torticollis, which you'll learn about in your pediatric course, so I'm not going to go into congenital. So acquired torticollis can be from ergonomical factors or positioning. And adult acquired and spasmodic torticollis should be treated conservatively with it. This is one time where you will use a soft C-collar because you want to allow that muscle to be able to rest. Heat or ice can be whichever the patient prefers. They should actually be put on some bed rest and given analgesics and muscle relaxants. Physical therapy may be helpful for persistent cases with spasmodic torticollis because it can become recurrent. They need to learn exercises and stretching techniques to help keep the muscles strong and prevent the spasms. Consider occupational therapy if ergonomic or positioning errors are causative of adult acquired. Degenerative arthritis of the neck is also termed cervical spondylosis. Because it is usually asymptomatic, when patients present, they usually have radiculopathy that is dependent on whichever nerve root is involved. So initially it's going to be asymptomatic, but when it does become symptomatic, it's because there's compression of a nerve. C6 and C7 is typically the involved nerve root, and it will cause paresthesias in the lower lateral arm, thumb, and middle finger. If radiculopathy is present without neurological defects, physical therapy for cervical traction, which actually will help stretch the spine and relieve the pressure on that nerve, and nonsteroidal anti-inflammatories are generally sufficient enough to manage it. If there are neurological defects, MRI of the C-spine would be indicated. Persistent pain not relieved with conservative measures may require oral or injectable steroids. I would recommend referral at this point. Remember, when you order some of these imaging studies, such as an MRI, what you are actually doing is you're telling the surgeon where to cut. So if you don't think it's a surgical case, MRIs usually are not of much benefit, and sometimes it would be more beneficial to go the course of therapy first and then just preserve the MRIs for those who failed therapy. Also, if you send somebody to physical therapy and the therapist finds some neurological symptoms, they're going to call you and say this patient needs an MRI. Low back pain is one of the leading causes of disability in the United States and one of the most common reasons for acute pain office visits. There are many different pathologies that can produce low back pain. Please make sure you review the tables on pages 819 and 821 in your textbooks for the red flags and the differential diagnoses. Most back pain with mild or no radiculopathy can be successfully treated with patient education, continued activity, non-opioid analgesics such as NSAIDs, and physical therapy. The absolute worst thing you can do is to put a patient on bed rest. When the muscles weaken and become atrophic, then they end up having more pain and increased spasm as they try to return to normal activity. So you want to maybe reduce the amount of activity that they're doing, but do not put them on bed rest. Gentle stretching and core strengthening exercises are important to control pain and strengthen the muscular support for the spine. So I do recommend early referral to physical therapy. Again, MRI should be reserved for patients who fail PT, who have severe radicular pain, or you have evidence of neurological defects. Before labeling a patient as disabled, they need to go through PT and have an evaluation by an orthopedic or neurosurgeon. If there are just herniated discs, I recommend just neurosurgery consultation because they can sometimes preserve or return functioning to normal without causing to have like fused vertebrae. If there is spinal stenosis or compression fractures, then you need to send them to orthopedics. Just a personal example, I had a patient who had a herniated disc, had no spinal stenosis, no arthritis, went to orthopedic surgery first. This was somebody in his 30s, and the orthopedic surgeon recommended a spinal fusion and to put the patient on permanent disability in their 30s. Got a second opinion from a neurosurgeon who said that we can simply clean up the disc, that fusion may be necessary, but it would delay it. It's now 20 years after the discectomy, and the patient never underwent fusion and is still functioning and working without a problem. So you really need to know that your pathology. An orthopedic doctor is going to give you an orthopedic answer. A neurosurgery surgeon is going to give you more of a neuro answer, but if they feel that orthopedics need to be involved, they would recommend usually dual surgery where both surgeons, a neurosurgeon and orthopedic surgeon, are present in the operating suite, and they both do what their specialty is. So just keep that in the back of your mind. Just because someone is unable to do the job that they currently do does not mean they can't do other jobs. So it's not uncommon for low back pain to become a chronic issue. So patient education is essential so they understand the importance of maintaining a normal BMI, engaging in regular exercise that maintains core strength, and applying good body mechanics with activity. A patient's not disabled unless they're disabled from doing any job. So that may be a difficult conversation with the patient that they maybe need to consider another occupation. Social Security disability, again, does not take into consideration the ability to perform the job you do now, but defines it as the inability to engage in any substantial gainful activity. Sometimes it is necessary to refer patients for job counseling or recommend they consider looking for a different job, and that can be a very sensitive discussion. There's a series of Medicare disability videos available on YouTube. There are just far too many of them to incorporate them into your module assignments, but I encourage you to look at some of them. They average about 8 to 13 minutes, and they do have some helpful information. Just as an example, I know someone who had extensive physical handicaps from a severe spinal injury with numbness, difficulty ambulating, lack of bowel and bladder control, and has to self-catheterize and wear diapers. He owns a garage in his own business, and he was denied disability unless he sold his business and his property. They cited that he could still manage the business because he still had normal cognitive function. They said he didn't really have to do the physical work, he could manage it. And I also know of a person who is in a wheelchair that was denied disability because she can work from home doing online teaching. There are many different options for people, so this issue requires education and counseling, and you will run into this often. People think if they can't do the job they do now, that they should be disabled. Low back pain with radiculopathy should be sent for an MRI if it's associated with recent trauma, neurological deficits, weakness, loss of tendon, reflexes, or bilateral lower extremity symptoms. The majority of herniated discs can self-heal with conservative measures such as physical therapy, anti-inflammatories. Although your book lists that initial management should be NSAIDs with 1 to 3 days of bed rest, it is more often recommended that patients reduce activity and avoid complete bed rest. I know this is busy, but the full article that this came from, which I got from Up to Date, is available in your optional course materials for Module 8. I would recommend that you do read that, even though it's optional. You don't have to if you feel like you're pretty familiar with this stuff. But the recommendations define conservative measures as non-narcotic analgesia and temporary activity modification for 2 to 4 weeks. If at inadequate response, they should then be referred to physical therapy and consider a short course of systemic glucocorticoids. Failure to improve at 4 to 6 weeks is an indication for neuroimaging with MRI. Red flags that warrant urgent testing include progressive or severe motor deficits, suspected neoplasm, suspected epidural abscess, urinary retention, saddle anesthesia, which is numbness in the perineal area, bilateral symptoms, or high suspicion of neoplastic, inflammatory, or infectious causes. Treatment then would be based on the underlying cause. Again, this is just a general approach to lumbosacral radiculopathy symptoms. Spinal stenosis, remember, is the narrowing of the spinal canal which compresses the nerve roots. Obesity plays a major role in the development of this, so patient education on weight loss and maintaining a normal BMI is paramount in its treatment. NSAIDs are beneficial, and exercises that focus on spinal flexion and core strengthening are also recommended. If the nerve root compression causes neurological deficits or patients do not respond to conservative measures, they should be referred. I am not going to discuss Cauda-Equina syndrome other than you need to know that the presenting symptom is saddle anesthesia with bilateral lower extremity weakness and possibly bowel and bladder incontinence. These patients should be referred to neurosurgery immediately. So that's one of those red flags. I'm also not going to cover vertebral fractures, as they most often will present to an emergency department. They most commonly occur secondary to trauma. Conversely, compression fractures often show up in primary care. These fractures are associated with osteoporosis and can present with varying degrees of pain that starts after minimal or no trauma. Patients often report that the pain starts after a cough, sneeze, driving over a speed bump or a pothole, some kind of abrupt insult, and it can be very minor. The most common areas are from T7 to T8 or from T12 to L1. As long as there are no neurological deficits, plain X-ray is sufficient to diagnose these. Treatment focuses on pain relief with activity modification, again avoiding bed rest, and physical therapy is highly recommended. Treating the osteoporosis is helpful, and the intranasal calcitonin has been shown to improve pain, so that is a really good option for these patients. Vertebral augmentation surgery may be indicated in some cases. I did place an article on compression fractures in your required reading for this module, so that one I really do want you to read. You will see this often. Bursitis is something you will also see fairly often in primary care, and it can occur from chronic repetitive use or trauma. It is very important that you rule out infection, so if there's any suspicion that it may not be just simple bursitis, you need to order a CBC to look for leukocytosis, a ESR or C-reactive protein, which will identify if there's maybe gout, rheumatoid arthritis, or infection. And if you are strongly suspicious of gout, you should do a uric acid level also. Conservative measures should be tried first with the Price mnemonic, which stands for protection, which may require splinting or protective padding. If it's your knee, you may need to tell your patient to wear knee pads if they're doing a lot of kneeling. Rest or avoidance of use of the joint or the activity if it's from repetitive use. Ice for 20 minutes every 4 hours. Compression with ACE bandages or neoprene compression sleeve, and elevation if it's appropriate to reduce edema. NSAIDs are generally recommended on a regular schedule. If you use them on an as-needed basis, that may help the pain, but it's not going to reduce the inflammation. You need that regular use for a few weeks to get the true anti-inflammatory effects. A prescription for naproxen 500 BID or Mobic 15 milligrams once a day are both good options, and be sure to instruct your patients to take them with food. Remember of the GI side effects. Refer patients to physical therapy for range of motion and ultrasound therapy, which may be beneficial for bursitis. If conservative measures fail to improve the discomfort within 2 to 3 weeks, you may consider joint injection, but again, make sure there's no evidence of infection. You absolutely do not want to inject a steroid into an infected joint. Injections should never be more frequent than every 3 months, and you need to remember that these injections do increase the risk of tendon rupture. Tendinitis may coexist with bursitis, and treatments are very similar. The only exception is that you do not want to immobilize the tendon for more than 48 hours due to the potential for calcification or scar formation, which could limit the range of motion. You want to keep these joints moving, maybe not as much, but you still want to do range of motion with these joints. Physical therapy is recommended early in the process because tendinitis generally becomes recurrent, and because it's often caused by repetitive use, patients will need to reduce or avoid the activity that's causing it. NSAIDs for at least 2 weeks for the anti-inflammatory effects, and consider corticosteroid injections interarticularly, especially if there's evidence of coexisting bursitis. Remember, you never want to inject directly into a tendon. Carpal tunnel syndrome may respond to splinting, but there's limited evidence that it's beneficial in the long term. Additionally, the use of steroid injections has not been shown to be beneficial in patient outcomes in the long term for carpal tunnel. Most patients with carpal tunnel syndrome will require surgical release of the tendon. Postoperative occupational therapy is essential and is generally ordered to start about a week after surgery. De Quervain's tenosynovitis is common in people whose occupations require pinch gripping. If caught early, splinting is generally sufficient with activity modification. Ergonomic evaluation of the work setting may be required. NSAIDs may be beneficial to help reduce the inflammation, and steroid injections may be beneficial if there is failure to improve with conservative measures after 3 to 4 weeks. Ganglion cysts are common and generally benign conditions. Many times they will resolve spontaneous without any treatment. Historically, people would take large family Bibles and actually smash the cysts, causing them to rupture, and then the body would just reabsorb the fluid. If the cysts become large enough to interfere with range of motion or become painful, they can be surgically excised. Aspiration can be attempted, but they generally fill back up again. And if you do attempt to aspirate, you need to use a large bore needle because the fluid in these cysts tend to be very thick and gel-like. Trigger fingers are stenosing tenosynovitis of the flexor tendon, and patients will have tenderness over the palmar aspect of the MP joint. And sometimes you can feel a small cyst there. They'll first report that they get intermittent locking of their finger, and they can often kind of massage that area to kind of release it initially, but eventually it becomes locked and fixed in a flexed position. That's the picture over here on the right. Steroid injections are recommended as first-line therapy, but they may require surgical tendon release. Dupuytren's contracture is fibrosis of the palmar tissue and is a progressive disorder with an insidious onset. So they're going to notice that just over time, that contracture becomes more present, and you'll kind of see this band forming that kind of looks like a tendon, but it's actually scar tissue. They are also treated with injections or surgery. I refer all of these to orthopedics, and it should be preferably someone who does hand surgery. Adhesive capsulitis will exhibit as a frozen shoulder with a loss of active and passive range of motion. There's just simply, you try to do range of motion and it's blocked. NSAIDs and physical therapy is recommended treatment, and the recovery is very lengthy. These patients should be referred to orthopedics if physical therapy does not improve any range of motion in 2 to 3 months. So if they're just not making any headway, you need to refer them. Calcific tendinitis generally develops in the rotator cuff following trauma or overuse. Non-steroidal anti-inflammatories, ultrasound with physical therapy, and rest usually resolves the discomfort, and it usually just presents as pain. It usually is not a frozen shoulder. They'll still have good range of motion with this. It's just very painful. Corticosteroid injections may be considered in refractory cases. Calcific tendinitis usually does not require surgical intervention. Rotator cuff damage can be chronic from repetitive use or secondary to an acute injury or tear. MRI is the best modality to evaluate for damage that may need surgical intervention. Remember that ordering an MRI should be based on patient symptoms and only if the patient fails to improve with conservative measures and physical therapy. Always ask yourself, is this a surgical shoulder? And if the patient says, I don't care what my MRI says, I'm not getting surgery, then you don't need an MRI. Injecting corticosteroids, remember, weaken tendons and increase the chance of ruptured tendons or even can propagate the condition and make it worse. So make sure you know what you're treating when you're injecting. Greater trochanteric pain syndrome generally presents as lateral hip pain and possibly some numbness in the upper thigh that's exacerbated by movement, particularly external rotation and abduction. Treatment most often is NSAIDs or corticosteroid injections. Conversely, myalgia paresthetica is caused by compression of the lateral femoral cutaneous nerve from wearing tight clothing and presents with pain or paresthesias over the anterior superior iliac spine and the anterior lateral thigh as depicted in red on these images. NSAIDs and avoiding constrictive clothing is the treatment. It's usually, from the belt line. People wear tight waisted belts or have a lot of equipment hanging on their waist. That will cause it, and it's more common in guys. I'm not going to go over hip fractures, avascular necrosis, or malignancy because treatment will be managed by specialists, and all of these conditions warrant referrals. Most of the fractures are going to show up in an emergency department. Avascular necrosis or malignancy may be something you pick up, but again, when you'll do the workup, and they will be immediately referred. Osteoarthritis and rheumatoid arthritis will be covered in other areas, so I'm not going to cover them, even though they're in that chapter. The Ottawa ankle rules are the gold standard for determining the need to x-ray an ankle. Radiograph should be obtained if there is bone tenderness at the posterior edge of the medial or lateral malleolar area or the inability to bear weight. Bone tenderness at the base of the fifth metatarsal or the navicular bone and inability to bear weight for at least 4 steps also require x-rays. All other ankle and foot pain should undergo conservative treatment using that Price mnemonic. And the last slide, which is basically chapter 55, we're going to talk about osteoarthritis and osteoporosis. Osteoarthritis treatment is directed towards pain control, preserving joint mobility, and reducing the progression of the disease. General measures should include weight loss to reduce joint burden if applicable, physical therapy to maintain or regain joint mobility and muscle strength, and aerobic activity has been shown to improve long-term functional outcomes, but you want to avoid joint overuse. Pain control can be achieved with application of ice or heat, whatever the patient prefers, topical analgesics such as capsaicin cream or topical NSAID creams, and transcutaneous electrical nerve stimulation, also called TENS units. They are relatively inexpensive and available for purchase without a prescription. You can get them online. I actually use one all the time and really do feel they help. Physical therapy uses these TENS units all the time also. When there are multiple joints affected, oral anti-inflammatory drugs may be required, but if it's just an isolated joint, try the topical stuff first. If the patients fail these measures, then I recommend orthopedic consultation. Because of the chronicity, I don't recommend starting joint injections for this condition in a primary care office. These people sometimes need viscosupplement injections if the knee is involved, or sometimes they need joint replacements if it's hip, knee, or shoulder. Surgical management for end-stage or severe osteoarthritis has been shown to be cost-effective and improve quality of life. Joint replacements generally only last about 15 years, so don't be too quick to recommend surgical evaluation in a young or obese patient, but rather reinforce the chronicity of the disorder and the benefit of the conservative therapies, and primarily weight loss first. Osteoporosis treatment is aimed at fracture prevention and improving bone mass. Recommendations for all patients should be smoking cessation, moderation of alcohol use, weight-bearing exercise, and adequate calcium with vitamin D intake. Pharmacologic treatment with bisphosphonates should be initiated when DEXA scan reveals osteoporosis and not just in the osteopenic state. Miacalcin nasal spray may be an option for those who do not tolerate the oral forms and have been shown to improve pain with compression fractures. IV agents are also available, but they have some pretty serious side effects, including atrial fibrillation and osteonecrosis of the jaw. So I recommend referring those patients to endocrinology for management. Estrogen therapy in women who are good candidates may be of benefit in the osteopenic state, but it should not be considered as first-line treatment for osteoporosis. Patients who first present with compression fractures or hip fractures need to be under the care of orthopedics, obviously for their fractures, but they also may benefit from endocrine referrals. So thank you for your attention. If you have questions, please send them to me. And again, there's some supplemental information that is available in the optional materials section of this module, and there's also some additional required readings, so make sure you check those pages in the module. Thank you.